Hello students, today's topic is common nutritional problems in India and their causes. We will look in detail for PEM, its incidence, signs and symptoms and treatment. We have to look into the causes and the preventive controls for protein energy malnutrition and how the dietary management of PEM is taken care of. The phrase "we are what we eat" is frequently used to signify that the composition of our bodies is dependent in large measure on what we have consumed. Food serves mainly for growth, energy and body repair, maintenance and protection. Food also provides enjoyment and stimulation, since eating and drinking are among the pleasures of life everywhere for everyone. As a consequence of dietary deficiency, several nutritional deficiencies with clinical manifestations and disabilities are encountered in India. To name: protein energy malnutrition, PEM, vitamin A deficiency, iron deficiency anemia, iodine deficiency, that is the endemic goiter, and of course the B complex deficiency. The first four are often referred to as Big Four and have been the concern of health authorities in the country. PEM, it is most common in preschool children, resulting in poor growth and development. Anemia, it is prevalent in all groups, highest prevalence being among pregnant women, preschool children and women during reproductive ages. Anemia leads to impaired work capacity, impaired resistance to infections, and most important, the poor pregnancy outcome. Vitamin A deficiency again is very common in preschool children, causing nutritional blindness. Goiter, due to iodine deficiency, results in thyroid insufficiency, impaired metabolism and mental retardation, and is seen across all the age groups. In 20th century, however, a new nutritional problem began to emerge in India, the problem of overnutrition and obesity. With increasing mechanization, changing lifestyles, fast foods, it has become a major issue. What is overweight? When the body weight is between 10 to 20% more than the desirable or the expected weight, we call it overweight. And when the body weight is 20% more than the desirable weight, we call it as obesity. Body mass index, BMI, and the waist to hip ratio are simple criteria to assess the degree of overweight and obesity. If we look at the causative factors of obesity, there are plenty. This slide will give you an overview of the causes of obesity. There could be genetic predisposition, there are environmental factors, there are behavioral factors, there are social factors, mental and physical disabilities, drug abuse, then there are endocrine disorders, and there are physiological factors. So if we look at obesity, we can say that it has a multifactorial existence. Now let us take BMI as a criteria to classify. Underweight is less than 18.5 kg per meter square. Now what is important is the normal range, which has been given as 18.5 to 24.99 for general, but in the Indian subcontinent there is an additional cutoff point of 18.5 to 22.99 because of the truncal or the abdominal obesity. However, once the BMI goes beyond 30 kg per meter square, it is classified as obesity and it can be class 1, 2 or 3. This has been given by WHO. Again, waist circumference and the waist to hip ratio become simple criteria to assess obesity. When the waist circumference is more than or equal to 102 centimeters, that is 40 inches in men, or greater than or equal to 88 centimeters, that is 35 inches in women, it is strongly associated with an increased risk for heart disease. Similarly, a waist to hip ratio of more than 1 in men and more than 0.85 in women is considered to be obese. Let us just look at the facts about overweight and obesity. In 2014, more than 1.9 billion adults, that is 18 years and older, were overweight. Of these, 600 million were obese. Overall, about 13% of the world's adult population is obese. In 2014, it was shown that 39% of adults aged 18 years and over were overweight. So, we can see there is a worldwide prevalence of obesity and it has doubled between 1980 to 2014. So, after looking at this brief overview of obesity, let us look at undernutrition. And that is what we typically call it as the Indian paradox. At one end of the spectrum, we have obesity as a major public health issue, and at the other end of the spectrum is undernutrition. There are many causes of nutritional problems. An important issue is that many children in developing countries are already nutritionally depleted by the end of the first year of life, because maternal undernutrition can cause low fetal accumulation of nutrient stores and secretion of inadequate amounts of some micronutrients in the breast milk. Improvement of maternal diet and micronutrient status is required to remedy this situation. During the period of complementary feeding, most households may be able to provide their young children with sufficient energy and protein from home-produced complementary foods. But many do not feed foods with an adequate energy density or a sufficient number of meals per day. There is also an issue of food security. It is defined as access by all people at all times to sufficient food required for a healthy and active life. It is now widely accepted that most of the undernutrition in developing countries is due to inadequate intake of protein energy, and that it is often associated with infectious diseases. A modest increase in cereals, legumes, oil and vegetable consumption by children will greatly reduce the prevalence of PM and growth deficits for children in developing countries, especially if combined with control of infectious diseases. Breastfeeding during the first few months of life can ensure an adequate diet, whereas bottle feeding remains a major cause for diarrhea and nutritional marasmus. Food availability too is a matter of concern. To nourish a population adequately, there must be sufficient quantity and variety of good quality and safe food in the country. Therefore, in most low-income and food deficit countries, a fundamental strategy of food policy is to improve and increase food production, which is a domain for agricultural experts. However, fact remains that agricultural production has to be improved. The question of access to food also remains a major problem. Access to food or food demand is influenced by economic issues, physical infrastructure, and also the consumer preferences. Per capita incomes and food prices are important determinants of food demand. Since the poor are the most vulnerable to food deficits and malnutrition, policies that increase their purchasing power will provide them with the potential to improve their nutritional status. Therefore, increased employment, better wages become components of policies and programs to improve nutrition. Food prices affect both supply and demand. Lower prices also give farmers less revenue for their produce. Poverty. Poverty is often stated to be the very root cause of malnutrition. Certainly, in most countries, it is mainly and sometimes only whose children suffer from severe or moderate PM or show evidence of vitamin A deficiency. In contrast, nutritional anemias and iodine deficiency disorders may not be confined to the poor. The experience of many developing countries show that a major reduction in poverty would have a significant impact on rates of PM in most communities of the country. Now, let us look at PM in detail. WHO and FAO defined PM as a range of pathological conditions arising from coincident lack in varying proportions of protein and calories occurring most frequently in infants and young children and commonly associated with infections. It is considered as the primary nutritional problem in India, also called the first national nutritional disorder. The term PM covers a wide spectrum of clinical stages ranging from severe forms like kwashiorkor and marasmus to the milder grades in which the main detectable manifestation is growth retardation. PM is due to the food gap between the intake and the requirement. Protein energy malnutrition is a group of body depletion disorders which include kwashiorkor, marasmus and the intermediate stages. Kwashiorkor is the body's response to insufficient protein intake but usually sufficient calories for energy, and edema is prominent. Marasmus represents simple starvation. The body adapts to a chronic state of insufficient calorie intake. Severe growth retardation, wasting are the cardinal features. Combined forms showing edema and wasting are described as marasmic kwashiorkor. In community surveys, heights and weights are most commonly used anthropometric indicators. Indices like weight for age, height for age, weight for height are derived from these basic anthropometric measurements. Some of the common classifications that are used in community surveys are: the first one, Gomez classification, which takes into account the body weight with reference to the expected or the standard weight. Grade 1 undernutrition is when the child is having 76 to 90% of the expected weight. Grade 2 is 60 to 75% of the expected weight, and grade 3 is less than 60% of the expected weight. Another major classification is Wellcome classification. It takes into account deficit in body weight and the presence or absence of edema. Now here it can be seen that when we say underweight, we are talking about a deficit of less than 60% in marasmic children, edema is absent. But when we are talking about kwashiorkor or even marasmic kwashiorkor, we are definitely talking about the presence of edema. In both the conditions, we are talking about severe conditions when the body weight is less than 60% of the expected weight. Indian Academy of Pediatric Classification is based on weight for age, and the cutoff level to separate the malnourished children is 80% of the standard or the expected body weight. Further, severely malnourished children are classified into grade 3 and grade 4 malnutrition. Grade 3 is when the body weight is between 51 to 60% of the expected weight, and grade 4 is severely malnourished when the body weight is less than 50% of the expected weight. FAO and WHO also give their classification for PEM as kwashiorkor, marasmic kwashiorkor, marasmus, nutritional dwarfing and underweight children. Again, it can be seen that whenever there is kwashiorkor, there is a deficit in both weight and height, and there is presence of edema. Let us look at the etiology or the causes for PM. Different combinations of many etiological factors can lead to PM in children, and that is why it is said to be having a multifactorial etiology. Some of these causes are diet, socioeconomic factors, infections, lack of knowledge, traditions, customs and beliefs, and among the social, economic, biological and environmental factors, the most common ones are lack of breastfeeding and giving diluted formulae to the child, improper complementary feeding, overcrowding in family, ignorance, illiteracy, lack of health education, poverty, infection, familial disharmony, and that is why we see a wide spectrum of protein energy malnutrition. Let us look at kwashiorkor. The term kwashiorkor is taken from the Ga language of Ghana. It literally means the sickness of the weaning. Williams was the first one to use this term way back in 1933, and it refers to an inadequate protein intake with a reasonable calorie or energy intake. Kwashiorkor is also called wet protein energy malnutrition because it is a form of PM characterized primarily by protein deficiency. This condition usually appears at the age of about 12 months when breastfeeding is discontinued, but it can develop at any time during a child's formative years. It causes fluid retention, what is known as edema. There is dry, peeling skin, and there is hair discoloration. Kwashiorkor was thought to be caused by insufficient protein consumption, but with sufficient calorie intake, and that is how it is distinguished from marasmus. However, recently micronutrient and antioxidant deficiencies have also been recognized as contributory factors to kwashiorkor. As against this, marasmus, it is a word derived from Greek word marasmos. It means withering or wasting. It is a form of severe PM characterized by energy deficiency and emaciation. It is primarily caused by energy deficiency, and it is characterized by stunted growth and wasting of muscle and tissue. It usually develops between the ages of 6 months and 1 year in children who have been weaned from breast milk or who suffer from weakening conditions like chronic diarrhea. The symptoms are severe growth retardation, loss of subcutaneous fat, severe muscle wasting. The child looks appallingly thin and limbs appear as skin and bone. The body is shriveled, the skin is wrinkled, there is a bony prominence. It is also associated with vitamin deficiencies. There is failure to thrive, irritability, fretfulness, apathy, frequent watery diarrhea and acid stools. The child is mostly hungry but sometimes even anorectic. There is dehydration, temperature is subnormal, muscles are weak, and conspicuously edema and fatty filtration is absent, which is so typically seen in kwashiorkor. Now, what is marasmic kwashiorkor? A severely malnourished child with features of both marasmus and kwashiorkor. The features of kwashiorkor are severe edema of feet and legs, hands, lower arms, abdomen and face. The skin is pale and hair, and the child is unhappy. There are also signs of marasmus, wasting of the muscles of the upper arms, shoulders, chest, so that you can see the ribs clearly. So if we look at the treatment for PM, it can be divided into 3 stages. 1. Resolving the life-threatening conditions. Number 2. Restoring nutritional status. And most important, ensuring nutritional rehabilitation. Let us look at the treatment part of it. First is the hospital treatment. The following conditions have to be corrected. Hypothermia, that is the low temperature of the body, has to be corrected. Hypoglycemia, the blood glucose levels have to be elevated a little. Infection has to be corrected. Dehydration has to be corrected. Electrolyte imbalance, anemia, and other vitamin and mineral deficiencies have to be attended to. Dietary management. The diet should be from the locally available staple foods, which are inexpensive, easily digestible, evenly distributed throughout the day, and increased number of feedings to increase the quantity of food. When the locally available foods are given, the acceptance by the child is also more. Then is rehabilitation. The concept of nutritional rehabilitation is based on practical nutritional training for mothers, in which they learn by feeding their children back to health under supervision, and again we underline this fact, using local foods. Vitamin and mineral supplementation is essential. Daily supplements of iron, about 60 milligrams per day, and folic acid, 1 microgram per day, should be given to correct anemia. Single oral dose of vitamin A should be given to all malnourished children on day 1. About 1 lakh international units for children below 1 year and 2 lakh international units for children above 1 year is a recommended dose. If there are any clinical signs of xerophthalmia, then 2 doses should be given on the first 2 days, followed by a 3rd dose 2 weeks later. Now, the most important aspect of PM is prevention. And how do we do it? Promote breastfeeding, develop low-cost weaning mixes, nutrition education and promotion of correct feeding practices, family planning and spacing of births, immunization, food fortification, early diagnosis and treatment. That is how we are able to control PM. Thank you.